Hello, this is a sort of a quick and dirty presentation about ultrasound basics. Hopefully it will be quick enough, but not too dirty. And this is just to tune you up for your CCSRMO Echo Teaching Day. Alright, so we're going to be talking quickly about the general ultrasound and some basic principles. The most basic principle is that the ultrasound probe emits sound waves, and these sound waves travel through the tissue. Some of these get reflected back onto the probe, and hence they are called echoes because they are echoes from that tissue. They could be seen as a bright image on the screen, and if they are seen as a bright image on the screen, we call the structure that the echoes have come from as echogenic. Some tissues are a bit different. They do not reflect the ultrasound waves back to the transducer, and we can't see them on the ultrasound. So those tissues are sort of anechoic. A quick word about the basics of a transducer. So this is a sort of a cross section from a transducer. The point that I want you to note is that there is an array of piezoelectric crystals or piezoelectric elements, and these are the sort of the brain in the transducer. As these crystals are hit by an alternating current, they emit the sound waves of a particular frequency that we like and send this through the tissues. The most part of the transducer acts sort of as an emitter, if you like, of the sound waves, and also the receiver. And most of this time is actually spent in trying to receive the ultrasound waves back, and only a fraction of time is actually spent emitting the sound waves. So this is very important, the piezoelectric crystals and the transducer. So how is an image constructed on the screen? Well, let's go through that sort of again, some of the repetition of what we just talked about. So generation of ultrasound beam by a transducer, we've already seen how that happens. Now the beam enters the tissue across a coupling gel that you put on the ultrasound probe and put that to the skin. And please try and use the specific ultrasound gel rather than anything lubricating that you come across. The beam enters the tissue, and the tissue can interact with the beam in multiple ways. It can reflect the ultrasound wave, and when it does reflect the ultrasound wave, we get the echoes. But instead of reflecting it back, it can either let the sound waves pass through, and then it would be an anechoic tissue, or it can scatter the ultrasound waves in various directions, in which a minimal component of the wave that had hit the tissue actually comes back, or it can cause refraction. So there is various ways in which the tissues and beam can interact. When there is a perfect reflection and the ultrasound waves are received back at the transducer, do we see a proper image of the tissue. What does the transducer do then is obviously creates an image by changing the ultrasound waves that are received back into an electric signal. The strength of the ultrasound waves reflected by the tissue and received by the transducer are reflected on the screen as brightness, and this is something that we talked about before. So if a tissue is a good reflector, we will see the we see it brightly on the screen. A typical example in cardiac echo is pericardium, which is highly refractile and appears as a very bright structure, which you would see. On the other hand, if the tissue does not reflect the echo back, and RBCs or flowing RBCs are an example, they are anechoic, as in they are seen as a black spot or not seen at all on the ultrasound scheme. Now the other important thing is that the way depth is measured on the ultrasound screen is actually based on the time that the ultrasound waves take to come back to the transducer. So the speed of the ultrasound wave through the tissues is a constant, let's say, so which means that the distance is directly proportional to the time taken by the waves to go to the tissue and come back. So if the rays come back from a tissue relatively quickly, then the machine judges that tissue to be superficial and treats it as such. When the reflections from the tissue are received with a delay, the machine assumes that tissue is deep, and hence that's the cause of delay for the ultrasound coming back to the screen. And one of these principles is going to be important when we're going to be talking about depth, or ascertaining or deciding the depth that you want to measure during your ultrasound scanning of a tissue, and how important is that. So these are some of the basic principles of the ultrasound generation and project. Coming to knobology, which is basically how you play with the knobs on the machine. Obviously, it's going to be different for different machines, but by and large, we're just going to touch upon the basic principles. And once you know those principles, you can sort of play around with knobs on any machine any way you like. So the general principles are that, well, there are some knobs that help you improve the clarity of an image, whereas there are some other knobs which help you focus on the structure of interest. We are not going to go through the details of all of these. These are best explained at the time that you actually are doing an ultrasound by the bedside, sort of. So these will be explained better to you when you come for the course. But just to give you an idea, so that you sort of know what you should be looking forward to. So talking about knobs to improve clarity, we are talking about gain, or 2D gain as we like to call it. There is something called as a time gain compensation, which we'll have a quick look at. Compression is another way to improve the clarity of the image, but that's not the sort of thing that we would talk to you about. It's a sort of a relatively advanced concept, and the machines that you are going to be working on should either not give you an option to change the compression, or even if they do, then you shouldn't be changing it. Then there are other knobs which focus on the structure of interest, which help you decide as to what to see and in some ways what to avoid. And these are the knobs, and these are the main ones that we are going to be talking about. And these are sort of the field of vision sort of a thing of the ultrasound arc or sector, if you like. And the two important considerations there are the depth that you're going to be scanning and how wide are you going to be scanning. The other thing is the use of a zoom. Again, this is best explained at the bedside, but that's another thing that you can use to focus on the structure of interest. And the other is something called as a focus itself, which is how you improve the clarity of a particular structure that you're seeing. And we're going to go through some of these relatively quickly, one by one. So gain. Now gain determines how intensely or how bright you see a particular structure, and in an ultrasound sort of a nomenclature, it determines the amplitude or intensity of the signal. Higher the gain, stronger the signal, and brighter the image, which means that if a tissue is not very refractile, then what you can do is amplify the echoes coming from that tissues, and rather than not seeing it very well because it is poorly refractile, you'd be able to see it much brighter and hence likely more clearly. But then it's easy to go overboard and see it too bright, and if you've got gain too high, you would need sunglasses, as one of the sonographers told me, to view the echo. That shouldn't really happen. So the gain must be optimized. If you've got a too high gain, it's going to act as a noise, and what it's going to do is that sometimes it's difficult to control the gain in a particular field of vision. So all the signals coming from a particular point are all amplified. That includes a structure that you really want to improve the gain on, but what you end up doing is just increasing the general gain. If you have, on the other hand, gain too low, then some of the important structures that you actually want to see, which are not very refractile, will not be seen. So basically, with all things in medicine, or most things in medicine, you apply the Goldilocks principle: not too hot, not too cold, and just right. Now we are going to talk about the ultrasound field. Ultrasound field is the ultrasound arc, if you like. So we're going to be talking about the depth of the arc that you choose and the width of the arc that you choose. Now, in general, you need to have the width and the depth optimized for the area of interest, and this is probably quite intuitive. If you have a greater field, as in if you have a higher depth and the bigger sector, is going to lower what we call as the frame rate. And frame rate in some ways is the rate at which the machine renews the image. Now again, it is very important that you have an optimal frame rate for cardiac echo, because heart is a moving structure and you want to be able to see those movements in real time. So if you have a very long depth or a very wide image, you may have a very poor image resolution, or you may have a very poor frame rate, in which case you might miss important details. Having said that, if you keep the field too small, or as in if your sector width is too narrow, then you may not be able to see enough of the heart that you really want to see. If your depth is too small, then you may not be able to see the deeper structure. Again, this sort of varies somewhat with the window that you're looking at, or the view that you're looking at. But again, the principle is to make sure that you see enough, but do not increase the depth too much. So a practical tip is that start with wide and deep field as a screening view, which means that you have a very long view, about 15 to 20 centimeters, and as wide a sector as you can choose, until you sort of start to vaguely see what you want to see, and then optimize the sector width and the depth. A quick word about the depth. Now, we know that increasingly we see obese patients in general and in critical care areas, which means that there is a lot of subcutaneous fat, and unfortunately that means that you have to scan at quite a big depth. Now, while you can scan at quite a width depth, and again I should have discussed that in the basic ultrasound principles, is that if you scan at bigger depths, then what you need to do is have a longer wavelength or a shorter frequency, because if you have a shorter frequency, that the rays are able to penetrate deeper into the tissue. Unfortunately, if you keep the ultrasound frequency low in order to reach deep areas, the resolution with these lower frequency ultrasound waves is not very good. So you may be able to scan deep, but you may not get a very good picture. So when it is pushed on you, as in you have to go to greater depths to be able to see a structure, then unfortunately you do not have much choice. But if you have a patient who does not need to have a deep sector, then try and keep the sector depth as low as possible, because if you keep the sector depth low, you're going to be able to use ultrasound waves of higher frequency, and you are going to be able to see a much better picture. On the other hand, if that is something that's out of your control, if you're going to an obese patient or you need to see a very posterior structure, then you need to have the depth, enough depth on it, which means that you will have to use the wavelength, or a higher wavelength, or a ultrasound wave of low frequency, in which case you may be able to get the depth you need, but you may not be able to get the resolution that you want. So it's a bit of a trade-off, like most things in life. So talking about gain, this is an inappropriately high gain on this picture, and you should be lowering it. And if you lower it, this is how it would look like. So here you've got your gain optimized. Here you've got too deep height, the depth, if you like. So you can see that on the scale, from the scale on the left side, that this is scanning at a depth of 30 centimeters. Again, you don't need 30 centimeters. We often start at that sort of a depth until we get a good view, and just to have a look at the structures posterior to the heart. Frequently, if you have a pleural effusion, then it's nice to be able to see that on a big depth. But as soon as you've located the heart, you decrease the depth. So in this case, you'll probably come down to about 15 or 18 centimeters, and that would be the optimal depth. As you can see, frame rate decreases with increasing the field of the scan, and if you pay attention, then the right lower end of the screen mentions an abbreviation FPS, which is the frame rate, and that is 36.4. If you decrease the depth, now you're able to see the structures better, and if you now see the frame rate, that has actually gotten the number has gotten bigger, which means that the rate at which the frame renews itself is faster, which means that you'd be able to see the moving structures quite well. So keeping the sector width as low or as less wide or as narrow as you possibly can is beneficial, within the limits, of course, that you should be able to see the structures that you want to see, and keeping the depth as small as possible is advantageous. And of course, the caveats with depth, obese patient, frequency, and resolution apply. So the next important concept is the focus, and the focus is important with regards to improving the clarity of a structure. It's a triangular control that you see on the screen, and I'll show it to you on the next screen as to how it looks like. The point of deciding where you want to put the focus is the structure that you want to most concentrate on. So if you put the focus opposite mitral valve, say for example, you'd be able to see mitral valve the best, and the structure beyond the mitral valve particularly not as good. And the principle behind the ultrasound principle behind that is the principle of divergence of the ultrasound wave. So to a certain extent, you can keep the ultrasound wavefronts parallel, and I won't go into the details because it becomes too physical, but you can keep the ultrasound wave front parallel for a certain distance, and after that distance the ultrasound waves start to diverge, and as they start to diverge you begin to lose the detail on the structures. So if you want a particular structure to be seen the best, what you can do is manipulate the position of the focus. So there is a control which moves the focus up and down, so you put the focus where you want the clarity of the structure. There are certain machines which have a facility of having what is called as a dual focus, where you can choose two foci if you like, and you'll be able to see sort of two structures which would separate depths sort of equally well. But most of the times in echocardiography there is almost always a sort of a single focus, so you can move that focus up and down to concentrate on a particular structure, but be mindful that almost always beyond that focus the rays are going to diverge and you're not able to see any further structures as well. Demonstrating that here, if you concentrate on the left hand scale side, you see a small triangle. That triangle is at the depth of about 8 centimeters, and that is the focus in this ultrasound scan, and that means that the ultrasound waves are focused at this point. They are the narrowest at that point, which means that the structure at that level would be seen the best, and the structures distal to it may not be seen as well. As I said earlier, you are able to move the structure up and down, the focus up and down, and then you can decide which is the structure that you want to concentrate on. So if you have an aortic valve vegetation, say for example, that you want to concentrate on, you can move it at that level. If you've got a problem with the posterior mitral valve leaflet having a vegetation, then you can move it down and be able to concentrate on that. So in terms of the practical tips in neurology, with regards to the depth, you start with a wide depth and deep field, just to have a very quick look as to what's happening in those fields. And once you have decided that where the structure lies, as in you found the heart on a quick scan, then you sort of optimize the field. You optimize the width of your screen, width of your ultrasound arc, and you optimize the depth, because if you haven't got those optimized, you're not going to generate a very good quality image. The second thing is to look at the gain. Now you've decided what oral structures do you want to see. Now is the time to decide how to see them. So you optimize the gain so that the structures look just the right and just the right echogenicity, not too bright or not too dark. And you can use the time, get a compensation to eliminate the noise. You obviously need to optimize the depth that we've talked about and adjust the focus to concentrate on the structure or the areas of interest. Now just a quick word about how to hold the probe. This is certainly one way of holding the probe. This is how I practice and I teach. So what you do is that you hold the probe right up at the junction of the transducer sort of thing and the cord, and you wrap 3 fingers on one side and put your little finger and thumb on the other, such that the thumb is at the cords. And the way, if you were to hold the probe this way, it's going to be very firm and stable in your hand, like that. So now the probe cannot move. It's been held very firmly. When you put that on the patient's chest, what I would advise is that you keep the whole of the palm, including and the wrist, onto the patient's chest. Patients don't seem to mind it. What it tends to do is spread the pressure that you are exerting on patients onto a broader area, and they don't feel the discomfort. They don't feel as if you're poking the transducer or the echo probe into their chest. But also you should notice, and I apologize, it's not being projected very well in the photograph, is that your wrist and your elbow should be in the same line. This would frequently mean that you have to raise the height of the bed, depending on your own height, of course. But you should have the wrist, the hand, sort of the hand, the wrist, and the elbow, and yourself all in sort of one line, as in your elbow and wrist should be at the same level, and your elbow should be very perpendicular to your shoulder. This will keep you comfortable and the patient comfortable too. Because if you don't do that, if you do like this, where your wrist is getting off the patient's chest or just about, you're going to develop a very sore elbow, and you're going to develop a very sore shoulder while you're scanning. On the other hand, if you don't hold the probe in a proper way, then what you might end up doing is putting too much pressure onto the patient's chest, and they are not going to like it. So you might as well give it a try while you're waiting to come for the course, to try and hold that probe in that way and put it on a patient's chest or abdomen or wherever else you like, to make sure that you got comfortable with the grip, and that the patients or the subjects that you are doing echo on don't feel too much of discomfort with you holding the probe like that. Some of the terminologies that we use with the probes are sort of demonstrated in this picture. This is not a cardiac probe, so this is a linear transducer, but it's a nice photograph which sort of shows all the movements that we need to talk about. Hence, I've taken that picture. So sliding the probe means moving the whole probe up and down, and this could be sort of up and down or medial to lateral. So sliding is moving the whole probe so that the footprint of the probe changes and it moves up and down the chest, say for example, or medial to lateral, for an example. The other thing is sort of rocking the probe. Here you just tilt the probe medially or laterally, and the footprint doesn't change much. Just a slight tilt is given medially or laterally. Rotation of the probe obviously refers to movement of the probe along on its axis, and this could obviously be clockwise or anti-clockwise. And tilt is sort of tilt predominantly sort of up and down, so with the probe facing the head end or the foot end, depending upon whether the tilt is up or tilt is down. So the most frequent thing that we talked about is tilt, up or down, rotation, clockwise, anti-clockwise, and sliding the probe up and down. So if you were to just familiarize yourself with these terms, it will make our communication a bit easier. Thank you very much for listening to this talk, and I hope to see you on the education day. Cheers.